I'm glad this is a small room because you can clearly see. Okay, hyperphoria, vertical eye deviation. So let's just assume, see, the first one, just look at the lips and the nose. You know, it's just a very fine difference. Move over next one, a little bit larger. So you can assume that's less than 1, that's 1, and that's 1.5. And anything greater than 1.5, let's say in the 4 to 6 range, by the way, I'll give you an overlook of what's coming up. 4 to 6 range is where seizure starts. Okay? Can you imagine a seizure patient trying to fuse this all day? His brain has, the fusion is done by the brain. It's a blending of two similar images. The brain, the child, the baby, the newborn, they prefer stereo. Even if they have eyes slightly crossed, they prefer stereo opposites. That's a key thing too. So that means the brain is going to constantly want to fuse things. That's where the strain comes in and the pain will eventually show up. Now, this vergence, when you have phoria, vergence is what corrects the phoria. It's like the amount of power needed to correct the phoria. So the average population has 3 to 4 diopters of vergence, base down vergence. Because if you have hyperphoria, you need base down vergence to pull it down. Base down, yeah. The right eye was hyperphoria. First of all, right hyperphoria, we always, when it comes to hyperphoria, you have to say right eye or left eye. Right eye, if I have right eye hyperphoria, right eye is higher, therefore the image is always lower. Prism doesn't shift the eye, it shifts the image of the eye. It moves the image to the eye. So if you have a base eye prism, when the light hits a prism, it always goes towards the apex. Okay, so this is the most accurate way of testing for hyperphoria. The photometer, you guys often behind this. Okay, and the dial is the Risley prism. That dial, the Risley prism is how we check we can turn that, check to see if it's vertically higher or lower, or horizontally right, lateral or ESO, exo or ESO. It's not much to say about it, just want to show you, that's how we test for it. That's, okay, this is next. Okay. So here's my 3 presentations that shows that 1.5 vertical prism diopters causes hyperphoria. This lady presented to me for a routine eye exam. After 38, she's had daily headaches for 38 years. Just because you have a migraine patient, it doesn't mean headache patient doesn't suffer as much. So the key finding here is she only has 1/2 diopter of hyperphoria, and despite 38 years of daily headaches, she doesn't have symptoms of migraine. She also had convergence insufficiency. Convergence insufficiency is where the eyes do not converge together. And so how we measure that, you guys need to do this for your babies and for your kids. It's often missed in the optometric exam. You just get a pencil pen, ask them to look at the tip of a pencil, slowly bring it in, try to keep it clear, bring it in, try to come to your nose, converging all the way towards your nose, so that if you see as it comes, if you see the eye drift out, we're measuring the near point of convergence. And this is very detailed. You'll be able to use this as a reference. I'm trying to explain seizures, migraines, and optometry all in 15 minutes. So I think focus on what I'm doing here, and you can just get a general idea. So when you go to your optometrist or you see a patient with migraine, you'll know what to look for. So near point of convergence, okay? It used to be that if you come up to 7 inches, I'm sorry, America we use inches still. If you come up to 7 inches, it's considered convergence insufficiency. However, the latest standard is now 3 inches. But a child needs to be able to come to 3 inches, and you can say, okay, you passed the convergence insufficiency test, and you don't have convergence insufficiency. And however, based on my finding, actually most kids these days, because they're constantly on the iPhone and whatever, or almost all kids can come right up to your nose. So we call that to the nose, TTN. So if you see something like TTN, expect. Oh, by the way, I want to know, does anybody in here treat migraine or seizure patients? Fantastic. Okay, great. All right. Okay. And by the way, anything that you're not sure on the validity, I encourage you to do your test, but use these as a pointer to look and then focus on hyperphoria and convergence. That's number one. Okay. Okay, case number 2. It's also they're all sad cases. They're generally on antidepressant. If you're a child, you're on anti-anxiety. So, so I had a lady who came in suffering 22 years of classic migraine, and now it's happening 3 to 4 times per week. She started treatment since toddler. Toddlers 1 to 3. So just went to all the finest, best migraine specialists, traveled the world basically. And her last visit, her migraine specialist said, "Can I help you anymore?" So here I am. This is my first case where I realized, I've been treating all these regular headaches and mixed headaches patients, and probably migraine patients, because in optometry, our ICD code, there's no coding, there's no separation between headaches and migraine. So we don't even know, we don't distinguish between the two. So here's the first time I'm seeing a patient exhausted all medical intervention, and so am I going to be able to help? So I was very, excited to find the results myself. After testing her, she had notice the very first visit, she only had 1 base up, and I said 1.5 is the standard across all migraine patients. So I retested her on visit 2, and boom, the 1.5 showed up on her second visit. Oh, by the way, on the first visit, when she returned, she said, "Oh, I love my glasses. My glasses now reduce my headache by it reduced it to once a week, from 3 to 4 times a week to once a week. That's basically 66 to 75%. And as I was preparing for this, I was figuring out, can I give more information out of my data? Yes, I can. So the information I'm getting is, I don't think anybody has tried this, but I think you can apply it to your specialty. If she has 1 prism diopter at the first visit, if I give her half, that's 50% more increase, 50% additional convergence, more power to compensate for her needs. And so I would expect maybe 50% reduction on the symptoms. Instead, she reports about a 66 to 75% on reduction. Okay. So she's ecstatic. A little prism helped her reduce further what medicine couldn't do. That she's so far done. Next, please. Oh, here's my first case, completely solved. And how it presented was a young child, classic migraine, gotten worse, and so I did my normal test. The only thing that stands out that was abnormal is he had 1.5 prism of vertical hyperphoria. So I gave him half a diopter prism. On the second visit, he comes back, his parents comes back and say, now, the only time he's getting migraine now, first of all, when he has symptoms migraine, sometimes, actually a lot of times, the neurologist will say migraine plus mixed headaches. So he comes back, parent says, yes. Oh yeah, I'm sorry, I forgot to use this. Yeah, sorry. Okay. Oh, yes.
Have tough competition.
Okay. Yeah, my arm moves around, so don't worry. Okay, we're in the case that it's the first time I have a case that's completely solved. The reason why it was solved because after 6 months of having no more migraines, the neurologist starts to decide to decrease his medication, cut it down by half dose. And then what happened? Migraine returned, and the reason is because I later found out on the following visit, the child stopped wearing his glasses during the summer. At the same time, they were trying to reduce the medication. So, unfortunately, he went go back. Medication was put back on. By the way, this child also had depression. I'm sorry, anxiety, and so. But after the visit number 4, every visit I always tell them you have to keep your glasses on full time to avoid. But so I restated the importance of keeping the glasses on, and no more migraines. And migraine medication and anxiety medication were stopped. By the way, I'm sorry, this child also was dealing with dyslexia, so seeing the school developmental psychiatry for dyslexia, and seeing the child psychologist for anxiety.
You gotta go.
Okay. Okay. So this is the first case that was solved, and in modern medicine, this is the first case. By the way, I saw all these about eight years ago, and I reported to a colleague, and he started testing hyperphoria on all his migraine, and he says, yeah, it definitely is. So so far that's the only thing. See, the reason why it's been difficult for the public or for the doctors to do it, hyperphoria is tested mainly by optometrists, unfortunately. I have nothing against ophthalmologists. My brother's an ophthalmologist. My father's a professor of optometry, pharmacology, and so, unfortunately, this is what optometrists specialize in. And we used to, there's a very important criteria. So first number you need to remember is 1.5 across all. Number 2 is the average vergence for the population is 3 to 4 to correct for that 3 to 4 prism of base up prism. And that's all based on this criterion where the Scher's criterion states that in order to sustain comfortable binocular vision, you need to have twice the amount of vergence to correct for the amount of hyperphoria. So if you have 1.5 base out hyperphoria, you should have 3 diopters of vergence to pull that eye down, to fuse. And if I give them 1/2 added to the 3, that's why they become symptomatic, and some they become solved. Some solve, some don't solve completely. So, and later on I will tell you what additional things you can do to kind of prevent additional strain. Now I'd like to move on to, I wanted to tie in because seizure is very similar in etiology and method, and the method of testing is pretty much the same. Seizure is 2 to 3 times more of hyperphoria, 4 to 6 range, and you could. This is my first patient, seizure patient I ever revealed to me. I asked him a question, and he said, "Yes, what triggers my seizure is eye strain." So 4 to 6, and that made sense to me. I'm the only one that was testing phorias. That made sense because the norm is 0. The second case I was involved in, and a patient, every time she removes her glasses, her seizure comes back. And the only thing that prevented the seizure was keeping her glasses on. I do not know her prescription of her glasses, but obviously, to be consistent, she had to be having a pretty moderate size of base-up vertical correction in the glasses. So this is all work that so far there's no other explanation, but this is really a scientific way of explaining it, and this has been done, for nearly a century. This is what optometrists specialize in, and so I would recommend that all your migraine patients, get them to an optometrist and check for base up and base, ask the optometrist to check for base up, base down, phorias and convergence. Make sure that they have enough convergence to correct for their phoria, and then check convergence insufficiency is such an easy test. Everybody should know how to do that. And, this way. Okay. Thank you. Any questions?
Any questions?
Oh yes, please.